Hello and welcome to the topic of non-small cell lung carcinoma in the module Respiratory Medicine. By the end of this topic, you should be able to define what is non-small cell lung carcinoma, discuss the causes and pathophysiology of this disease, outline the clinical features, list investigations which can help with the diagnosis of non-small cell lung carcinoma, and understand the principles of management of non-small cell carcinoma. Let's get started. The term non-small cell lung cancer or carcinoma applies to the various types of bronchogenic carcinomas, those arising from the lining of the bronchi, which include adenocarcinoma, squamous cell carcinoma, and large undifferentiated carcinoma. So what is the difference between small cell carcinoma and non-small cell lung carcinoma? There are several key differences, including the outlook. In a person with small cell cancer, the cancerous cell appears small and round under the microscope. The cells of non-small cell lung cancer are larger as compared to the small cell lung cancer. The vast majority, which is 85% of lung cancers, fall into the category called non-small cell lung carcinoma. Let's take a look at the physiology of the lungs. The respiratory tract comprises of 4 layers: the mucosa, submucosa, muscular layer, and adventitia. The respiratory tract is also divided into the conducting portion and the gas exchange portion. The conducting portion extends from the nasal cavity up to the bronchioles, and the alveoli is the gas exchange portion. The conducting portion is mainly lined by ciliated pseudostratified columnar epithelium with goblet cell, which acts as the mucociliary elevator. Gradually, as it goes down along the respiratory tract, simple columnar and cuboidal epithelium takes over. The gas exchange portion is lined by thin squamous epithelium and type 2 pneumocytes, which secrete surfactants. The pathophysiology of lung cancer is very complex and incompletely understood. It is hypothesized that repeated exposure to carcinogens, cigarette smoke in particular, leads to dysplasia of the lung epithelium. If the exposure continues, it leads to genetic mutations and affects protein synthesis. What is non-small cell lung carcinoma? Non-small cell lung carcinoma is a common type of lung cancer, and like all cancers, non-small cell lung carcinoma begins at the cellular level and causes abnormal cells in the lungs to reproduce rapidly and out of control. So non-small cell lung carcinomas are carcinomas which are cancers of the cell lining of the surface of the lung airways, and these include the bronchi, bronchioles, and the alveoli. The leading cause of developing this type of carcinoma is smoking cigarettes. So as mentioned, the causes are multifactorial, which comprises of the genetic components and the environmental factors. However, there are several well-known factors that significantly increases the risk of developing lung cancer. Tobacco smokes contain at least 40 types of chemicals that are potent carcinogens. They can increase the risk of lung cancer by a factor of 10. Besides, the most common occupational risk factor is asbestos exposure, which increases by the factor of 5. Smoking and asbestos exposure are synergistic, so a smoker with asbestos exposure has 50 times increased risk of developing lung cancer. Other risk factors include exposure to arsenic, radon, nickel, chromate, and aromatic hydrocarbon. Note that coal dust exposure is not related to lung cancer. Cryptogenic fibrosing alveolitis, also known as idiopathic pulmonary fibrosis, has been reported to be associated with an increased risk of lung cancer. However, coal dust is a factor that is not related. There are 3 main subtypes of non-small cell lung carcinoma, including squamous cell carcinoma, which makes up 25% of lung cancers, adenocarcinoma, 40% of lung cancers, and large cell carcinoma, which makes up 10% of lung cancers. Adenocarcinoma is the most common form of non-small cell lung carcinoma, accounting for approximately 30%. This type of cancer is seen in non-smokers or former smokers. Lung adenocarcinoma usually begins in the peripheries of the lungs and can grow quite large before it is detected. The squamous cell carcinoma accounts for approximately 40% and is associated with smoking. Often centrally located, it grows rather slowly and metastasizes late. This type of tumor is associated with serum hypercalcemia due to parathyroid hormone secretion causing a paraneoplastic syndrome. The large cell carcinoma is rare with less than 10% of lung cancer involvement, and this type of cancer also occurs in the peripheral lung tissue. It is a poorly differentiated tumor having sheets of large malignant cells and is often associated with necrosis. So, what is the clinical presentation of lung carcinoma? Patients are often asymptomatic until the advanced stage of the disease. Studies have shown that an initial presentation, 55% of patients have distant metastasis, 25% has regional metastasis, and only 20% is still localized. The symptoms produced by primary tumor depend on its location. Cough is the most common complaint. The symptoms of peripheral tumor are cough, dyspnea, and severe pain if there's parietal pleura and chest wall infiltration. For central tumor, patient present with cough, dyspnea, wheezing, and hemoptysis. If there's loco-regional spread, patient can have hoarseness of voice due to paralysis of recurrent laryngeal nerve and diaphragm paralysis due to phrenic nerve palsy. Patient can also experience dysphagia if there's esophageal compression. And for Pancoast tumor, the tumor may compress the brachial plexus root, causing intense neuropathic pain in ipsilateral upper extremity. Patients with metastasis often have constitutional symptoms, bone pain, headache, altered mental status, seizure, nausea, and vomiting depending on the site of metastasis. So, how can we diagnose lung carcinoma? When lung carcinoma is suspected, a plain radiograph of the chest can be used to visualize if there's any lung mass or pleural effusion. Nevertheless, a normal chest X-ray does not exclude the disease. The diagnosis can only be confirmed by obtaining samples of histopathological examination. Depending on the location of the tumors, this can be done in several ways. Sputum cytology may be helpful to check for a central lesion. Endobronchial lesion can be visualized, and the biopsy can be obtained through bronchoscopy. A peripheral lesion requires a CT-guided transthoracic needle biopsy. If pleural effusion is present, diagnostic thoracocentesis can be done, and the cytology studies can be done on the pleural fluid to check for malignant cells. If a diagnosis of lung cancer is established, the cancer should be staged to determine the severity of the disease. This can be done through a CT thorax and upper abdomen to look for nodal involvement and contralateral lobe involvement. Sometimes, mediastinoscopy may be performed prior to surgery as CT scans do not always show mediastinal lymph node involvement. To assess for regional and distant metastasis, a PET-CT should be performed. If patient complains of bone pain or the alkaline phosphatase ALP is raised, bone scan is indicated. A CT scan or MRI of the brain is also indicated if patient has focal neurological deficit, altered mental status, or experience seizure. Other investigations for lung cancer include the routine metabolic profile such as full blood count, renal profile, and liver function test. Electrolyte imbalance can occur in lung carcinoma patients too. Hyponatremia may indicate presence of SIADH, and hypercalcemia more associated with squamous cell carcinoma, which must be excluded. Liver metastasis should be suspected if the liver enzymes are markedly deranged. With the advancement of technology, more advanced tests such as the molecular testing is now available as a tool to guide treatment. This test identifies patients with advanced non-small cell lung carcinoma who may benefit from targeted therapy or immunotherapy. Targeted therapy can be given if there is EGFR, ALK, or ROS1 mutation. Immune checkpoint inhibitors such as pembrolizumab can be used if there is PD-L1 expression. As for the screening of lung carcinoma, the American Cancer Society recommend annual screening with low-dose CT scanning to patients aged 50 to 80 years who have at least a 20-pack-year smoking history and either continue to smoke or have quit within the past 15 years. The staging of lung cancer is based on the 8th edition TNM classification for lung cancer. Stage 1A is for tumors less than 3 centimeters. Stage 1B is for tumors between 3 to 4 centimeters. 2A is for tumors between 4 to 5 centimeters and has not spread to the nearby lymph node. Stage 2B is for tumors 5 centimeters and less and has spread to N1 lymph node within the lung, or if the tumor is more than 5 centimeters but has not spread to any lymph node. Stage 3A is for tumors more than 7 centimeters or tumors of any size that has spread to ipsilateral lymph nodes, and lymph nodes including the peribronchial, hilar, and intrapulmonary nodes. Stage 3B is for tumor less than 5 centimeters and has spread to ipsilateral, mediastinal, and or subcarinal lymph node, or if the tumor is more than 7 centimeters and has spread to ipsilateral lymph node including the peribronchial, hilar, and intrapulmonary nodes. Stage 3C is for tumors more than 7 centimeters and have spread to contralateral mediastinal, contralateral hilar, ipsilateral or contralateral scalene and or supraclavicular lymph nodes. Stage 4A is for tumors that have spread to the contralateral lobe, or if there is pleural or pericardial involvement, or has spread to single extrathoracic metastasis. Stage 4B indicates the presence of multiple extrathoracic metastases in one or more organs. For non-small cell lung carcinoma, only 20% are suitable for surgery, and it has a poor response to chemotherapy. Patients can be offered radiotherapy, targeted therapy, or immunotherapy if they are eligible. In stage 1A, only surgery is needed. For stage 1B to stage 3A, surgery with adjuvant chemotherapy is offered. For stage 2 to stage 3B, if the tumor is unresectable, a combination of chemotherapy, radiotherapy, and immunotherapy such as durvalumab is given. For metastatic disease, the treatment differs between those of squamous and non-squamous cell type. Stage 4 SCC is treated with cisplatin-based chemotherapy with or without pembrolizumab. Stage 4 non-squamous are treated with targeted therapy with or without cisplatin-based chemotherapy and pembrolizumab. Now, surgery is the treatment of choice for stage 1 and stage 2 non-small cell lung carcinoma. The different kinds of surgery that can be done are lobectomy, which is removing a section of the lung, pneumonectomy, removing the entire lung, wedge resection, which is removing part of a lobe, chemotherapy with cisplatin or carboplatin in combination with gemcitabine, docetaxel, and topotecan, which can improve life expectancy. If an operation is not reasonable due to the general condition of the patient, radiation therapy with curative intent is indicated. Palliative treatment options are offered for patients with advanced tumor specifically to relieve obstruction, dyspnea, and pain. Even though surgery is one of the mode of therapy for bronchial carcinoma, there are certain contraindications to surgery, and these include unresectable tumors such as those with complications like superior vena cava obstruction, a tumor near the hilum, and presence of vocal cord paralysis. The FEV1 being less than 1.5 liters for lobectomy or less than 2 liters for pneumonectomy. Other contraindications include malignant pleural effusion, advanced disease such as in stage 3B or 4 where metastasis is present, as well as a poor functional status to begin with. So let's summarize. Bronchial carcinoma is a malignant tumor characterized by uncontrolled and abnormal cell growth in lung tissues. Bronchial carcinoma is largely declassified into small cell and non-small cell lung carcinoma, each having its own distinct features. Diagnosis begins with symptoms and identification of physical signs in high-risk population. Investigations help with establishing a diagnosis and assessing the extent of the disease to decide on best management. Early stages of non-small cell carcinoma are resectable. Radiotherapy and chemotherapy can be done following surgery or for those tumors that are not resectable. Palliative therapy is provided for advanced tumors for relieving discomfort symptoms and improving quality of life. We have come to the end of this topic. Thank you.